Welcome everyone to Concurrent session number 13, Innovations in Consultation and Emergency Care Delivery. My name is Jocelyn Kohlmaier and I'm with Canada Health Infoway, co-host of eHealth 2022. This session includes two 15-minute oral presentations. If you have any questions or comments for our speakers, please type them directly into the Zoom chat and we will address them as time allows. You are also encouraged to connect with the speakers after the session via the virtual event platform. Now I'd like to welcome to the virtual stage our first presenters, Lindsay Bertrand, Manager, Physician Informatics at Nova Scotia Health /IWK Health, and Dr. Ashley Miller, Chief Medical Information Officer at Nova Scotia Health /IWK Health. Over to you, Lindsay.
Thanks so much, Jocelyn. And thanks everyone for joining us today. As Jocelyn said, my name is Lindsay Bertrand, and I'm the Manager of Physician Informatics at the One Person, One Record team in Halifax. And I'm here with Dr. Ashley Miller, who's our Chief Medical Information Officer. And we want to speak to you today about how we're growing virtual care in Nova Scotia through the establishment of an eConsult proof of concept. So while we haven't been formally assessed, Nova Scotia is at HIMSS level 1, maybe 2 in most areas. And our healthcare system is predominantly paper-based. We have 3 disparate clinical information systems and hundreds of siloed applications. So as you can imagine, our paper system contributes to a significant challenge in accessing information. There's a low degree of interoperability. We have a lack of transparency for our primary care providers and patients on where to send clinical information. We have a limited sense of referral status and specialist wait times, and all of this contributes to care inequity, increased administrative burden, and inefficiencies in the health ecosystem in general. So with all of this in mind, we conducted a provincial needs assessment to identify standardization priority across the province regarding physician documentation workflows. So providers responded, indicating that consult referral was a huge gap in our current system. And they identified a provider-facing registry, which is something we don't have, access to specialist care, improved workflows, and integration of any new digital solution with our 2 provincial EMRs as key components of a new workflow. So in partnership with the Department of Health and Wellness and supported by Canada Health Infoway, we decided to trial an alternative workflow that would demonstrate value within our current system. So eConsult was identified as a priority for a variety of reasons, most notably improving access to specialist care, improving our long wait times for access to care, and ongoing issues with inappropriate referrals. In our system, clinical questions are generally resolved through a phone call or through traditional referral pathways. And those are either fax-based or fax to email. And this creates congestion on our wait lists. And a significant amount of these referrals to be resolved by eConsult. So it was a relatively new concept in Nova Scotia, and we had to begin by actually defining what it means. So eConsult is an asynchronous, consultative, provider-to-provider communication within an EHR or web-based platform, and the sending provider actually enacts those treatment recommendations. So when we looked at the eConsult process, it actually prompted an exploration into the ideal state for our ambulatory care workflows. And our goal was and is to position eConsult as part of the established pathway for our patients. So this diagram outlines multiple potential alternatives to our traditional referral pathways. And we feel that this will improve patient care. We consider eConsult to be an integral process step towards our technology-enabled practice. So the Ocean platform by Cognizant MD was selected to test our eConsult workflows. In Nova Scotia, we have 2 provincially approved EMRs, TELUS MedAccess and QHR Curo. So Ocean was able to integrate seamlessly with both of those and allow those without an EMR to actually use the platform directly. So the integration piece was significant to our providers, as in a current state rounding exercise that we conducted, we found out that most providers log into 4 or 5 technology systems for each clinical encounter, which is significant inefficiencies there. And Ocean also offered the Health Map, which is a robust provider directory, and that was key for our province because, as I said, we don't have a provider-facing registry. So we assembled our 13-member deployment team consisting of students and clinical leads, and they were educated through a train-the-trainer model. So engaging students throughout this process benefited both the program and the students because it gave them implementation experience and really contributed to a valuable internship with our program. The deployment team members also served as the ongoing first point of contact for our providers. So we wanted to ensure that clinicians had a direct contact to someone if they got into trouble because of that administrative burden piece. We wanted to decrease that as much as possible. So Cognizant worked closely with us on KPIs and developed another provider survey, both sending and receiving providers because assessment metrics were key. And so after our initial kickoff meeting, our team was fully trained within 17 days. Our standard eConsult form was customized, and within 3 weeks, we were ready to begin onboarding providers. So this is just a snapshot of our timeline that demonstrates the agility of the project team. So ongoing collaboration, positive working relationships, those were all key to the success of this project. And because of that, the tight timeline was no issue. We actually had a great time during the implementation phase. And our participating specialists and specialties were recruited through a variety of channels. So we reached out to Doctors Nova Scotia, who offered comm support, which was amazing. And the call was also sent out through health newsletters within Nova Scotia Health and IWK Health. So 33 specialists or specialties were recruited and over 60 primary healthcare providers. So that's both primary care physicians and nurse practitioners. And providers determined for themselves whether they would be sending, receiving, or both. So specialists were encouraged to send referrals, send eConsults, and family practice specialties like family practice ops could also receive eConsults. And we were also intentional about exploring novel use cases for eConsults. So traditionally, we know this has been heavily adopted by medical specialties. But for example, one of our radiologists reported that she gets approximately 5 to 6 calls per shift with questions about what study to order. So therefore, DI was a priority to onboard to eConsult. So I'm going to hand over to Ashley now, who's going to take you through some of our assessment metrics throughout the project.
Thanks so much, Lindsay. So this proof of concept is live and in action. So this is just a snapshot of some of our initial data, and everything that I'm presenting today is relevant to May 24th. So it's changing as we speak. So as of that date, we had completed 140 consults, which represented 21 specialties and 6 cities. As you can see, not unexpectedly, some of the medical specialties predominate. So general internal medicine, which is my specialty, hematology, gastroenterology. And this mirrors some of the evidence that's been produced by Ontario related to eConsult. There is a predominance, but as Lindsay mentioned, we are starting to explore some novel applications for eConsultation, which maybe are in line with what other jurisdictions are looking to do, such as surgical subspecialties and diagnostic imaging. In terms of the value of eConsult to the Nova Scotia context in particular, the geographic distribution is critical. And as you can see, there's a representation, although there's a predominance of the consultative providers in the Halifax core, which is where our academic center is. There actually have been referrals coming in from across the province. This is particularly relevant in the Nova Scotia context because a lot of our medical providers in rural or distributed sites are quite busy with their non-ambulatory work. So for example, in my own specialty of general internal medicine, many of the rural internists are very busy taking care of the ICU and providing emergency-based care in hospitals. So ambulatory capacity is a huge gap. So eConsult actually allows me as a provider who's located in the central zone in the academic center to actually provide support to those more rural distributed sites in an area where local physicians maybe don't have as much capacity. And that's borne out by this distribution. In terms of our ability to achieve some of our targets, so we do have a set target of response within 72 hours, which in contrast to our ambulatory care waitlists in many specialty areas, which exceed years in the Nova Scotia context. In my own context, 3 months for a relatively urgent, up to 6 to 9 months for non-urgent. This is pretty profound how quickly we're able to respond. So as you can see, the majority of consults are responded to within 24 hours, and we're meeting our target of within 72 hours within 80% of the time. And I will mention that this doesn't delineate business days. So if a consultation is submitted on a Friday afternoon and a provider gets back to them on, for example, a Tuesday afternoon, although it fits within just that target of 3 business days, it wouldn't be denoted in this evidence. So we're definitely meeting that target, and that is improving over time. In terms of the actual experience, we have been surveying providers. We haven't had quite the response rate we had hoped for, but we're enacting some strategies now to try to enhance that. I mean, mostly it's just providers are extraordinarily busy, and although clinical care works into their workflow, obviously the addition of a survey is less easy to justify in the context of a busy clinic day. But nonetheless, we have gotten some quite rich feedback from these surveys already and hope to continue to receive additional feedback. And overwhelmingly, providers have found this intervention positive. I actually personally have participated in the proof of concept as a general internal medicine specialist receiving e-consultation, and I have had a phenomenal experience with this platform. So just to summarize some of the survey results. So as you can see, 92% of the time, there's no further intervention required. So that suggests that we've actually mitigated the need for referrals. So we're actually offloading some of those ambulatory care wait times. And that was supported by a follow-up question, which asked what providers would have done in the absence of eConsult. And as you can see, a significant proportion would have initiated some kind of outreach to a specialist, either through a formal consultation or through a phone call. And what we know from our specialty colleagues is that although phone calls are welcomed, and we're always very happy to support our primary care colleagues, it's quite disruptive to our day-to-day workflow. So for example, if you're on call in the emergency department and you receive a call for a non-urgent issue, that can actually distract from the flow of care. So it is ideal to have an asynchronous platform that allows you to address that question on an urgent basis in a timely manner, but not necessarily disrupting your day's workflow. In terms of satisfaction, as I mentioned, providers are overwhelmingly satisfied. So with eConsult itself as a modality of care, we had a very high response rate, and similarly, the platform itself was rated quite highly. Many of the comments related to the platform specifically did relate to the integration process, and as Lindsay mentioned, it's been quite a shared experience with the platform providers to enhance that integration process. So this has been a work in progress. And in terms of actual agreement that this is an important modality of care, 100% of providers surveyed agreed with that statement. So I want to get quickly to key learnings. I do see a question, how long did it take to realize that benefit? So that's live. So just over the first few months of the project, that has been the response from the primary care providers who are referring. So we asked them after completion of the eConsult, so once they've closed it, did this actually mitigate the need for a referral? And they're reporting yes. Maybe your question is alluding to the fact that perhaps things would happen later and there would be a need for referral after the fact, but we haven't heard that from our providers, and it hasn't been my experience. I personally audit the eConsults I've done, and none of them have resulted in additional care. So as Lindsay and I both mentioned, EMR integration is probably rated #1 as of importance to our primary care providers. And that's because we know that their workflow does not allow them to log into a separate platform. So the fact that we've created integration with EMRs has been critical. As specialists, we don't have access to EMRs, so we log into the platform. So there's still some discrepancies in terms of the time required for me to log into a hospital system sometimes to obtain additional information, but that's a work in progress, and we're working towards a provincial clinical information system, which hopefully will solve that problem. We definitely need recognition from a provincial perspective. Right now, there is no billing code or any other form of recognition for e-consultation. So it's really the goodwill of providers to engage in asynchronous care. And that's true of provider to provider asynchronous care and also provider to patient. So for example, my amazing family doctor uses Health Myself through her EMR and will communicate with me asynchronously, but there's no mechanism for recognition of that work. So it's really on a voluntary basis for providers. So obviously, if we want broad uptake, we need to incentivize that work. We definitely need to figure out how we're going to address some of those big implementation concerns, and definitely how it aligns with other initiatives within the province, such as our clinical information system and efforts such as through our perioperative network to actually develop very robust electronic referral pathways for the province to address ambulatory wait times. We definitely need to understand, again, remuneration. So how do we actually fund this and make sure that it's integrated into our pathways of care? But I think most importantly, our key learning has been eConsult as a standalone modality actually doesn't realize its full potential until it's integrated into pathways of care. So in our proof of concept, we're very much initiating the referring provider, initiating the eConsultation, but we know from our local context that often referrals in the traditional system are very appropriate for asynchronous care. So in my own practice, about 40% of my referrals, once I actually review the referral, I have determined that it is appropriate for asynchronous care, meaning that my recommendations wouldn't be influenced by seeing the patient. And often that's questions such as interpretation of laboratory abnormalities, medication optimization questions, or sometimes sort of care navigation questions. So this is going on, what do I do next? So in those 40% of the time, it's my feeling that that could be resolved through eConsult, but I don't have any mechanism to do that right now as a specialist. So alternatively, what I often do is end up just dictating a letter back, summarizing my recommendations, and then asking the family doctor to let me know if that's sufficient or if they still feel a referral is required. And then, of course, the ongoing need for integration and remuneration has to be addressed if we expect broad uptake of this modality. I just see a question about a delegate. So in our experience right now, where physicians are not relying on a delegate, I guess depending on the workflow within your clinic, it would potentially be possible in future state. Although in reality, I think one of the benefits of eConsult is the ability to exchange in real time clinician to clinician conversation. So although some eConsults are resolved just by sort of this is my question, this is my answer, what we have seen is that there's several scenarios in which providers actually have sort of an asynchronous chat about the case. So in that case, it wouldn't be as amenable to a delegate because the delegate wouldn't necessarily have the clinical context, but certainly something that we could explore in future states. So I'll just end there, and thank you so much. If you have any questions, please reach out. I will mention I am, although I'm the Chief Medical Information Officer for NSH and IWK, I am on maternity leave. So you'll get a bounce back on this email, but I do occasionally check it, and please feel free to reach out via Twitter. Thanks so much.
Great. Thank you so much, Lindsay and Ashley, for sharing your Nova Scotia Health story. And I think we addressed most of the questions in the chat, but if people do have more questions, please reach out to Lindsay and Ashley directly or through the virtual platform. Up next, we have Dr. Devin Singh, Pediatric Emergency Medicine Physician and lead for Clinical Artificial Intelligence and Machine Learning at the Hospital for Sick Children. Over to you, Devin.
Perfect. What a great presentation from the team before, and I'm really excited to be here talking to everyone today. And what I want to talk about is clinical automation in emergency medicine with machine learning medical directives. And so I am the lead for clinical AI at Sick Kids in emergency medicine. I'm also the founder and CEO of Hero AI, which is a health tech startup in partnership with Sick Kids that's actually trying to help us translate these types of algorithms into practice. And so you'll see how that comes into play in a sustainable way. And first off, one thing that we need to recognize, near and dear to my heart as an emergency physician, is that our emergency departments across the country are under siege. There's overcrowding. There's tons of patients arriving to our emergency departments. Some organizations are saying that our health system is on life support. And certainly as healthcare workers, we're feeling that, and we're seeing that with our patients as well. Some of the stressors around waiting very long to see a physician in an emergency department. And so in response to that, early on in the pandemic, my research team and I came up with this idea of machine learning based medical directives. And that's what we'll talk about today. And so let's take a very common use case. This little 8-year-old guy here, he's at home with his mom. It's a beautiful sunny day, and he's meant to be playing about in the backyard or out with his friends, but he's laying in bed with tummy pain. Really common problem that all of you with kids would have experienced, or maybe yourselves having some similar symptoms. Now, the spoiler alert here is that this kid has appendicitis, and if it's not seen quick enough, it may actually rupture, leading to adverse patient outcomes. And so what would typically happen? This little guy and his parent would come into our emergency department. Their data would be plugged into our electronic healthcare record system. Things like vital signs, presenting symptoms, age, weight, just different demographic details. The nurse doing an initial triage exam and writing free text notes. And so we know that there's lots of rich data that's here. But unfortunately, when an emergency department is really busy, this patient may wait 4 to 8 hours to be seen by someone like myself or one of our talented residents working at Sick Kids. Now, also imagine this kiddo presented to their community hospital initially. They may actually be even upstream in the workflow, waiting a really long time, getting assessed, and then being transferred in to our emergency department. And so you can see how the time really stacks up. And so, after I assess the patient, I realize that, he needs an abdominal ultrasound to rule out appendicitis. This is another maybe 2 to 4 hour wait, depending on how busy we are, to get that ultrasound done. And when you think about that in the grand scheme of things, there's lots of stakeholders involved here in order to go from diagnosis of this patient's appendicitis to actually treatment and recovery. We've got our diagnostic imaging technicians or the radiology residents overnight, the general surgeons, we got to book an OR, and we also have to arrange nursing support and an inpatient ward bed. And so there's lots of pieces that go into this, and these prolonged wait times really just delay things. So we asked ourselves this question: with the data at triage, could we actually build a machine learning model to predict the need for that downstream test? Because often the nurse knows, often I know reading the triage note, this patient likely has appendicitis, needs the ultrasound. Often the parent knows as well. And so what we did is we took any data point that was available at triage, so all of the points that I had mentioned before, and we plugged them into 3 very common types of machine learning algorithms: logistic regression, random forest, and deep neural network models. We tried all 3 because I wasn't sure which one would work. So when I was writing the code for these, maybe a logistic regression would work, which has some benefits because it's a really commonly used model. It's lightweight, cheap to deploy, but maybe it's a sophisticated problem and we actually need a deep neural network model. So we tried all 3. And here's one of our area under the receiver operator curves for our ability to take the triage data and map it to predicting the need for an abdominal ultrasound for these patients. This looks really good to start off with. You see the higher the numbers here, the better. What you're seeing on this curve is the true positive rate here mapped against the false positive rate here. And so you get excited initially because you see such great numbers and you wonder, okay, great, I'm gonna automate all of these ultrasounds. But if you want a true positive rate of 100%, which means any kid who needs an abdominal ultrasound for appendicitis will for sure get one, you're going to end up having a false positive rate of 60%. That's huge, right? So that doesn't work. Even though the model is really good at detecting this, when you actually think about translation into practice, it still will have a high false positive rate to capture all of these true positives. So we humbled ourselves and realized that we need to increase the model's precision, which means decreasing the false positive rate. So going in this direction. And if we can make the false positive rate really, really low, such that when the model does fire, we feel really confident that kiddo needs the ultrasound, well, then maybe we could automate ordering the ultrasound. So maybe the algorithm could actually order the ultrasound even before they're seen by a physician, so that the test can be done while the patient is waiting. And that's what we've done here, is we've set the threshold of where the model will operate to be much lower here. And so maybe we'll catch 10%. You might argue maybe we can get 20% of all of the cases potentially automated. And if we did that, we would save 162 minutes on average, just waiting to have that ultrasound ordered. So there's a bit of efficiency there. But then, we asked, well, if we could do it for appendicitis, which is a really complicated problem to model, maybe we could do it for forearm fractures. And we realized we can automate ordering for x-rays potentially. Maybe we could do it for ECGs. That works really well. You can see this one is an even better performing model. We could also do it for things like urinary testing or testicular ultrasound testing. You might think, well, urinary test is so easy to do, but try to convince a 3-year-old to pee into a cup, and it's a whole song and dance. It takes hours, actually, often, and often bribery with treasure box toys. And so, having lead time to saying we need this right away, right after triage, gives that family that time to get these tests done while they're waiting for their healthcare provider. Testicular ultrasounds are a surgical emergency when it relates to testicular torsion. And so there's clearly value add there. And so we recognize, though, that if we reduce the false positive rate to increase the precision, we are going to miss a bunch of cases. Like in this case here, all of this above this threshold point, all of these are missed cases potentially. So we can't just send those kids home. But what we can do for translation purposes is create a dual-pronged pathway. And so now our kiddo with the tummy pain comes into the emerge, data is put into the EHR. It can then be automatically fed into our machine learning algorithms. And if the model fires, we can automate ordering that abdominal ultrasound, getting the test done before someone like me sees the patient so that I can go straight to disposition planning and diagnosis. But for all those kids that we're going to potentially miss, they can go down the standard care pathway, making sure that we're not actually missing the need for doing a test. And the hypothesis that we're going to try and figure out now is if we do automate fragments of tests for many different use cases, will that actually still make the all the kids who go down the normal pathway, will that actually increase efficiency overall for our system? And so this is what we're looking into now. We've also explored themes around explainability. And so here, this is looking at a bit of a complicated plot to look at, but it's looking at the actual deep neural network model for predicting abdominal ultrasounds. And it's showing us what are the most important features that goes into making that prediction. And so here, for example, blue represents you don't have tummy pain. And so if you're missing that as a presenting symptom, the model thinks that you're less likely to need an abdominal ultrasound. Or if after the nurse's assessment, there's some concerns of appendicitis, which is represented in this red on this side, the model is more concerned about appendicitis and then could potentially place an automated order. We can also do this on a patient by patient basis. So if you're thinking about this idea of clinical automation, well, really, we need to be able to communicate to patients directly, and we need to provide explainability to patients in a direct fashion. And so there's opportunity for us to do that with patient by patient explainability. Now, the last thing that I want to jump into really quickly is that we recognize that we would not be able to actually translate these models into practice because we didn't have a platform. And so from this need, Hero AI, a health tech startup company, was born in partnership with Sick Kids. But what's interesting is we couldn't really build a company around doing just research. We needed to find things in the hospital that we could leverage as sort of a budget line to be able to build and solve like operational problems and clinical problems, and then leverage a built platform for enabling our clinical research. So for example, our hospital needed predictive dashboards. And so we've built dashboards that have things like the current census and the future predicted census. We wanted to have provider-facing mobile apps to provide alerts to the right provider at the right time when things might be unsafe in the emergency department. We also wanted, as a hospital, to be able to connect with our patients in an automated way. And so we've built a patient-facing application that can do virtual care, can assist with navigation when coming to the ED, and can do things like pain scales in an automated way. But if you think about building those solutions out that have budget lines attached to it, suddenly now we've created the platform we need to explore our research even further. So we can do things like taking EHR streams, predicting when a patient is having pain, and actually have a patient fill out their pain scale and automate that. We can start to predict things like when a patient has autism or when they have a surgical emergency and provide automated coordinated care. Or again, when the emergency department is unsafe or when triage nurses maybe need support. But for our use case now, we have a funded platform where we can explore how do we deliver to an actual family an alert around automated ordering or a machine learning medical directive. And so we can take that data stream, feed into our models, order the ultrasound potentially, but what do we actually say to the family? How do we gain consent? What do we need to show to the family? This has been an area of research we weren't able to do before, but now with a platform that solves many different problems, suddenly we have a sustainable solution, not sort of hung up on waiting for grant funding to come in. It's something we can now surge forward with and explore with our patients and co-build this part of the interface together, which is exciting. The final thing that I'd like to say is that really the end vision here could be translating our models into the patient home. Now that we have a platform with mobile devices that are in families' hands and with a boom of wearable technology, we wonder, could we start to gather this type of symptom data and actually automate orders coming in from the home directly to the hospital, totally rethinking the way we deliver care. The final slide that I'll end with is that we do need to think about equity. So we're building really cool technology. I think we're going to radically change the way we deliver care for lower acuity patients in our emergency department and for some with high acuity issues. but we need to do assessments around racial bias, especially with the way machine learning models are predicting. We need to make sure there's access to the hardware, that our patients, especially if we translate to the home, have access to internet so they can participate in these types of solutions, and that AI has to be for everyone. And these are big issues to solve for it before we think massive scale beyond the walls of sick kids. And so thank you for the opportunity. It was so great to present today.
Thank you, Devin, for that fascinating look at pediatric emergency medicine. There's 2 questions, I believe, but unfortunately we are out of time. So I'm hoping that you'll be able to answer those by directly responding to the chat or through the virtual platform or by email. So next up, I would like to invite all attendees to join our exhibitors for networking and discussions in the virtual trade show. And that is accessed through the top of your screen. See you there. Bye-bye now.